Hello and welcome to Lecture 7 of the Understanding the ECG lecture series. My name is Fiona Cam, I'm a cardiology registrar, and in this lecture we're just going to cover some bits that I haven't managed to fit into any of the other lectures. So our learning objectives for this lecture are: 1, to recognize the ECG features associated with hyperkalemia, so that's high blood potassium. To describe the initial management of a patient with hyperkalemia associated with ECG changes, to recognize the ECG features associated with the development of hypothermia, and to understand the differences in ECG presentation between pericarditis and a STEMI. So this is our standard recap on how to read the ECG systematically. We start with details, moving on to whether it's calibrated correctly, the ventricular rate, rhythm, and cardiac axis, before looking at the P wave, the PR interval, the QRS complex, both in terms of breadth and amplitude, the ST segment, and finally the T wave. Okay, so hyperkalemia is high blood potassium levels, and it's defined as a potassium greater than 5.5 millimoles per litre. And it's unlikely that you're going to see ECG changes until the potassium gets above 6 millimoles per litre. Potassium is really important for generating a membrane potential, and it's the gradient of potassium between the intracellular fluid, where there's lots of potassium, and the extracellular fluid, where there's normally relatively low levels of potassium, so normally 3.5 to about 5 millimoles per litre, and it's this gradient that's absolutely vital. And as the potassium in the extracellular fluid is increased, this results in easier depolarization of particularly cardiac cells, leading to hyperexcitability. So causes of hyperkalemia, well, there's decreased elimination of potassium, and that's relatively common, and that's seen in renal failure with a number of drugs, including ACE inhibitors, and in conditions like Addison's disease. There's increased intake. That's unlikely to be a primary cause of hyperkalemia. You'd have to eat a ridiculously large number of bananas for your body to retain that much potassium. Another big category is release from cells. So particularly burns, acidosis, tumor lysis syndrome, and hemolysis can all cause a large release of potassium from cells. And as you probably remember, the intracellular fluid contains a lot more potassium, so only a few cells proportionally have to release their potassium for a lot of potassium in the extracellular fluid to develop. And you can get a pseudo-hyperkalemia, which can be due to hemolysis of the blood sample itself. So potassium from inside red blood cells is then released into the serum, and so it can appear like there's more potassium, and that's a common cause for reported hyperkalemias in either the hospital setting or from blood tests taken by GPs, because they can often sit around for quite some time waiting to be processed in the lab. And the other cause of pseudohyperkalemia is the use of an EDTA bottle, which is the purple-topped bottle used for full blood counts. If you use them to run a U and E level, including potassium, you'll get a hyperkalemic reading because EDTA contains potassium. Okay, so what are the ECG features of hyperkalemia? Well, the first is the presence of tented T waves, and this tends to occur somewhere between 5.5 and 6.5 millimoles. In my experience, it tends to occur after about 6 millimoles. And this is an ECG showing tented T waves. So you can see that there's a narrow base with a very high T wave. And I think that a lot of people talk about height of T wave versus the QRS complex, but really when you're talking about tented T waves, it's the narrowness of the base proportional to the height. And you can see this is a very narrow base compared with that height. And it looks like if you were to sort of press your finger down on the top of that T wave, that it would hurt, which is very different from a normal T wave. And its total duration is really quite short, at about 160 milliseconds here. You also get a shortened QT interval. So you can see here we've used a tangent method. If you go back to lecture 1, if you've forgotten about that, And you can see this dark blue line here is the duration of the QT interval, and that's actually pretty short at 340 milliseconds. And then you tend to get PR prolongation and loss of the P wave, and that tends to occur with slightly higher levels of potassium, so once you get above about 6.5 millimoles, and you can see that this PR interval in the same trace has become borderline long here, and that P wave is really quite on the small side if you think about it. I've obviously blown it up, so it's quite a big complex, but actually looking at the number of small squares there, it's only about 1.5 millimeters across and 0.5 millimeter high. And then you get broadening of the QRS complex, and this happens at about 7 to 8 millimoles. And you can see here that this is a really broad QRS complex. And this is actually quite pronounced. This person's potassium was somewhere in the region of 9.5. And then you start to get a sine wave pattern. And you can see this is almost developing that sine wave pattern. But once it gets very extreme, it starts to pretty much look like a sine wave. So you get this downward for the QRS complex, and it's upward for the T wave. And then it can just go into sort of asystolic arrest. Okay, so here's an example ECG. Feel free to go through it in your own time, pause the lecture, and then we'll go through it together in a second. All right, so no details available here, but you can see that the technical calibration appears to be normal. The heart rate, if anything, is probably slightly on the slow side, isn't it? Appears to be going at about 40 beats a minute. Rhythm, it appears to be regular, so the gaps between the QRS complexes appears to be the same. The axis appears to be somewhat abnormal here, doesn't it? So it appears that the QRS complex is upward in lead 1, but downgoing in lead 2. So that certainly points us towards a left axis deviation here. I think the P waves are pretty difficult to see. I mean, looking at that rhythm strip, I really can't see any obvious P waves here, which is unusual in a situation where you've got a regular rhythm. Certainly you can get ventricular rhythms, but you'd expect if they're going this slowly to still see P waves. And even if you had a junctional rhythm, unless you've got some problem with the sinus node, you still expect to see P waves here. So that is something that's a bit bizarre. As a result, PR interval can't be calculated. Right, the QRS complex is really broad. You're looking at probably in the region of 160 to maybe 200 milliseconds here, particularly if you look at those lateral chest leads. V6 looks very broad. The ST segments themselves don't look particularly abnormal, but these T waves look quite pronounced, don't they? I think it's hard to say that they're really tented T waves at this stage, but I think that they are very high compared with their neck or their base, particularly if you look at that rhythm strip. And so overall, here we have no clear P waves, but a regular broad complex bradycardic rhythm. And we have this broad complex with quite pronounced T waves that almost are looking sinusoidal. So I think if I saw this ECG, I'd be incredibly concerned that this patient had quite severe hyperkalemia. And I think you guys can all see that the broad complexes that we're seeing on those chest leads, I mean, they just look very weird. And they certainly don't look like a clear bundle branch block. And this isn't going fast enough for it to be ventricular tachycardia because this is a bradycardic rhythm. So you've got a broad bradycardia that doesn't look like a bundle branch block, but is broad complex. And you've got very pronounced T waves and this very broad QRS complex. This couldn't really be anything but hyperkalemia, or at least that would be the first thing you have to rule out. So what's the treatment pathway for hyperkalemia? Okay, well, as usual, with anybody who might be unwell, it's an ABCDE approach. Okay, so your observations, you need to get IV access because that's required for all the treatment you're going to give. You need to send bloods off for the lab, particularly looking for confirming that they've got hyperkalemia, but as well you should be sending off some of the bloods that might give you an indication as to why they might have hyperkalemia. So your renal function would be particularly useful here. A full blood count to look for hemolysis would also be very useful. You should send a blood gas off of some kind because that will give you an almost immediate potassium reading back. You should certainly be getting them onto ECG monitoring and a 12-lead ECG. So if you have done that and you find that you've got ECG changes with your hyperkalemia, then the first thing you should be doing is giving them some degree of calcium. And most guidelines recommend calcium gluconate, and the dose is 10 mils of 10% calcium gluconate. This is one of the few drugs where I think it's very important that you do know the doses, and the medical school will normally expect you to know the doses because it's a true emergency medication. And the calcium here doesn't do anything to change the concentration of potassium, but what it does is act as a myocyte stabilizer within the myocardium. And so it reduces the chance of getting a dangerous arrhythmia developing in the heart itself. Some guidelines and some practitioners say that you should use calcium chloride, or certainly can use calcium chloride as an alternative, and some sources suggest that's actually even better than calcium gluconate. But I think for finals and for most clinical practice, I think calcium gluconate is the one to know, and it's 10 mils of 10%. And once you've given a single dose of this, you should certainly recheck the ECG, and you should keep giving doses until the ECG starts to stabilize. And in particular, what you should be seeing is that QRS complex starting to narrow, certainly, if not the T wave starting to resolve as well. So once you've sort of stabilized the myocardium, then the next thing is to try and drive some of this potassium out of the extracellular fluid. And the sort of fastest way to do that is to give some insulin. So insulin is a driver of potassium into the intracellular fluid, and you want to give some either immediate or fast-acting insulin. The best one to give is probably NovaRapid, which is an immediate-acting insulin, and you should give 10 units of that. Some trusts will only have ActRapid available, and that's okay, but you certainly shouldn't be using any kind of intermediate or long-acting insulin. This should be rapid, immediate-acting insulin if at all possible. And with that, the guidelines suggest that you should be giving dextrose, and that's to prevent you becoming hypoglycemic with all that insulin you're giving. And the classic instruction is to give 50 mils of 50% dextrose. And that's what most guidelines say, and in fact some trusts still insist that that's what you give for hyperkalemia. But I think it's important to realize that 50% dextrose is essentially like treacle. It's very thick and it's very difficult to get into a patient's vein, and it can also be very irritating on the patient's vein itself. And given that all you're trying to do is give that same amount of dextrose, there's really no reason, unless you're very limited in the amount of fluid you want to give a patient because of very bad heart failure or something of similar ilk, there's no real reason not to give a larger amount of fluid at a lower concentration of dextrose. For example, 125 mils of 20% would be absolutely fine as well. And so unless your guidelines specifically state it has to be 50 mils of 50% in whatever trust you're working, I would strongly recommend looking for those slightly lower concentrations. And the other thing you can give is a salbutamol nebulizer. And again, it's a beta agonist, and this also forces potassium into cells. This is a very temporary measure. I'm not a huge fan of giving salbutamol nebulizers. You will find that they're in the guidelines, and so certainly if nothing else is working, it's very reasonable to try it. But I'm not a big fan for a couple of reasons. One, I don't think it's particularly effective from my personal experience, although I appreciate that's anecdotal evidence. And the second is I have a sort of qualm about giving somebody who inherently has an unstable myocardium a beta agonist, which is going to hyperexcite the myocardium. We know that when you give salbutamol nebulizers, you can certainly make patients tachycardic, and I think doing that in a setting of hyperkalemia seems relatively counterintuitive. However, it is part of the guidelines, and you should know that it is a potential treatment. I think once you've started to try and stabilize the patient and try and control their potassium, nothing's going to help until you really deal with the cause. The vast majority of the time, the cause for hyperkalemia is acute kidney injury or acute on chronic kidney injury. And so they need fluid to try and get them passing urine in most cases, unless they're profoundly overloaded. And if they're not passing urine and they're not improving, then obviously hyperkalemia is one of the key indications for initiating dialysis. So, I think, again, if you've got a patient who's got quite significant hyperkalemia, and certainly one who's got ECG changes, you should be escalating to a senior relatively early. And the plan from there should be to escalate to somewhere where you can provide dialysis if necessary, and that's often intensive care overnight. And the key message to take away from this, certainly from a cardiac point of view as the ECG lecture, is that you really need to keep giving calcium gluconate until that ECG normalizes. Okay, and I can't emphasize that enough. Okay, so here's another ECG example. Feel free to pause the lecture and go through it, and then we'll go through it together. Okay, so hopefully you've had a chance to go through this ECG. So starting at the top, I haven't provided you any details, but let's say for the sake of argument, this person was found on the side of the street at 3 in the morning. From a technical point of view, it appears to be calibrated correctly, looking at that rectangle on the left-hand side. From a heart rate point of view, it doesn't look to be particularly abnormal. Looks like we're going about 60 beats a minute here. And it appears to be pretty regular. So the R waves appear evenly spaced apart. And I think I can make out P waves in lead 2, which appear to be upwards, suggesting that we've got sinus rhythm. In terms of cardiac axis, that appears to be normal. So we've got upward going QRS complexes in both leads 1 and 2. So we've got a normal axis there. And in terms of P waves, well, let's have a look at those in a bit more detail. So I said that I think I can see P waves. And I hope you can agree with me, there's pretty clear P waves here. But there's quite significant interference here, isn't there? And I'll tell you that this isn't just that the nurse didn't attach all the leads fully because she was very busy or anything like that. This is good quality ECG performed. And so there is quite significant interference. Okay, PR interval. Well, I think it looks a little bit on the long side, doesn't it? So if we pull this out here, we can see that there's about 6 small squares there from beginning of P wave to beginning of QRS complex. So it's about 240 milliseconds. So they've got a degree of first degree heart block, haven't they? So moving on to the QRS complex, I'm going to blow up a couple of leads here for you. And hopefully some of you may have noted these bits right here, this weird little sort of uptick at the end of the QRS complex. Which doesn't really look quite normal, does it? And I think these are probably Osborne waves, or as they're also called, J waves. And I'll come back to those in a second. So ST segments, I think, broadly look all right. I think the person who was initially looking at this ECG has obviously highlighted the ST segments in V6. And I think it'd be tempting to think that they're slightly raised, but I think if you look at that first complex in V6 where the ST segment does look raised, you'll notice that the reference point you're using is actually from lead V3 just before it switches over. And when you look at the ST segments in the other 2 complexes in V6, actually they're pretty isoelectric. So I don't think there's any real significant ST segment changes. T waves, they look all right actually, don't they? I can't see any obvious inversions that I'd be particularly worried about. I think it's hard in AVF because there's so much interference at that point. But what I will blow up is I just want to talk about the QT interval here. So here's our tangent method, going back to lecture 1 for it. And here it is from the beginning of the QRS complex through to the end of that T wave there. And that's 460 milliseconds. And the heart rate, as we said, is about 60. So there's no real correction required because the correction's aim is just to normalize it to a heart rate of 60. And so 460 is certainly getting on a little bit. And in a man, this would be prolonged in a woman, this would probably be considered borderline, because truly prolonged is above about 470 in a woman. So we've got some prolongation of this QT interval as well. Okay, so how do we put this all together? Well, we've got a patient with a heart rate of 60 who's been found on the floor in the middle of the night. They've got quite significant interference on the ECG. They've got these J waves or Osborne waves, and they've got a prolonged PR interval and a borderline or slightly prolonged QTC as well. So these findings altogether are in keeping with hypothermia, actually. And so to highlight those findings that really point us in that direction, one is the PR and QT interval prolongation. The second is this Osborne or J wave, this little wave just where the J point normally would be that flicks up. And this interference is almost certainly shivering. So just to go through the ECG findings of hypothermia. So one is bradycardia, which is often quite pronounced. I appreciate in our example ECG, the patient wasn't bradycardic, but often you can get quite significant bradycardia down into the 40s or even 30s. You get this shivering in the patient, which presents like an artifact on the baseline. Now, I think it's important to note that shivering may actually stop once you reach severe hypothermia. And so a lack of that artifact, if you've got all the other features of hypothermia, is actually more concerning. You get these Osborne waves, which you saw on that example ECG. It's that little positive deflection at the J point. And you get prolongation of the intervals, particularly PR and QTC prolongation, and you can start to get QRS broadening as well. Now, I haven't covered the treatment of hypothermia in this lecture because I think it's somewhat outside of the scope of the lecture, but that will be covered in other parts of your medical course. So having talked about hypothermia, I now actually want to move on to talk about something completely different, which is pericarditis. I know that we briefly touched on this in lecture 2 when we were talking about pericarditis being an ischemia mimic on the ECG at least, but I think it probably deserves a little bit more discussion than that. So pericarditis is inflammation of the pericardial sac, which is a sort of sac that lines the outside of the heart, and its major function is to allow the heart to beat without having too much irritation or resistance from the other structures in the thorax. When pericarditis occurs, one of the complications that are likely to occur are either the development of a pericardial effusion, so fluid building up in the pericardial sac, or myocarditis, which is when you end up getting inflammation of the myocardium itself. Now, in most cases, pericarditis is self-limiting and doesn't develop any complications. And actually, with a little bit of treatment from some anti-inflammatory agents, normally settles by itself. I think the development of myocarditis is certainly more concerning because that can have effects on either arrhythmias or can, in serious cases, lead to heart failure. And pericardial effusions can be worrying because if they get large or expand quickly, then they can compress the heart itself and lead to cardiac tamponade. In terms of presentation, pericarditis tends to present with chest pain, which is eased on sitting forward, and when you're listening to the heart, you may hear a pericardial rub, and that's often been described as the same sound as walking through fresh snow. So causes of pericarditis, well, most are infectious. In fact, the vast majority are actually idiopathic and thought to be secondary to a viral infection. And the vast majority of infectious pericarditis is from viral infections, particularly echoviruses. Some are caused post-myocardial infarction. You can either get early pericarditis in the first couple of days, and that's due to direct inflammation of the pericardium from the myocardium that is dead or dying, underneath it. So that can cause a direct inflammatory response in the pericardium, or you can get this autoimmune pericarditis that occurs about 4 to 6 weeks later, which is called Dressler's syndrome. You can get a uremic pericarditis, and indeed this is one of the complications of renal failure. The reasons why it occurs aren't clearly established, but it is a complication of uremia that you should look out for if you've got patients with severe kidney failure. And you can get inflammatory pericarditis, particularly rheumatoid arthritis, lupus, and scleroderma are all big causes or potential causes of pericarditis and other serositis. So what about ECG findings? Well, I think the key is that you often get this widespread ST elevation with this concave shape. Now, importantly, that doesn't tend to occur in AVR. As you remember, AVR is almost the mirror image of lead 2 and kind of is looking at the heart from that top right position. And so it doesn't really have a traditional view of the ventricles in the same way that the other leads do. So you should get ST depression in AVR, in pericarditis. But it's often widespread and it's got this concave sort of saddle-shaped appearance to it, which is really quite different from the ST segment elevation you get in myocardial infarctions like we looked at in lecture 2. You can get PR depression along with that, and that is also pretty widespread. You should be looking for the height or the amplitude of the QRS complexes. If they're small, that should make you concerned about whether you've got a pericardial effusion, because if you've got fluid all around the heart, that sort of acts as an electrical insulator and reduces the amount of signal that gets through to form the surface ECG. So these small QRS complexes in pericarditis should make you think about whether you need to get an echocardiogram to have a look at whether there's fluid surrounding the heart there. And I think there's a lot of confusion about pericarditis, particularly because these typical findings, this widespread concave shape ST elevation, is only present in about 60% of cases, and often this finding of this slight ST elevation can be quite easily confused with benign early repolarization, which is a sort of completely benign finding that we briefly mentioned in lecture 2 as well, where you get this very small amount of ST elevation, which is often quite widespread and is completely benign, and normally the patient's completely well with benign early repolarization because it's an incidental finding, whereas with pericarditis normally they have chest pain, but there can be quite a lot of confusion between these two. So here's an ECG example. Feel free to take some time to go through it, and pause the lecture and then we'll go through it together. Okay, hopefully you've had a chance to go through it now. So let's start at the top. So the details are that this patient's got some chest pain. We can see that it appears to be calibrated normally, looking at those rectangles on that left-hand side. The heart rate looks to be a little bit fast, doesn't it? So if we pull this out, we can see that the RR interval here is 12 small squares, so sort of 2.5 large squares. That's 480 milliseconds for that RR interval. So you can take 60 seconds divided by that 0.48, and that makes it 125 beats a minute. This is exactly the same as just doing 300 divided by the large squares. It's just doing it with timings. In terms of rhythm, it appears to be regular. There's an equal gap between each of the R waves, and I can also see P waves before each QRS complex that appear to be upright in lead 2. So this appears to be some degree of sinus rhythm, sinus tachycardia. The cardiac axis looks to be normal, doesn't it? You've got upward going QRS complexes in lead 1 and lead 2, so you've got a normal axis. And as I said, the P waves are upright in lead 2, and they appear to be pretty normal shape and size. They certainly don't look particularly large. PR interval, well, in terms of duration, the PR interval looks fine, but let's have a look at lead 2 again. So if this is our isoelectric line, you'll see I've taken the reference point just before the P wave starts. You can see that there's actually quite significant PR depression there. Okay, so although there's no PR interval prolongation, there is PR segment depression there. So moving on to the QRS complexes, you can see that actually they're narrow, certainly, and in terms of amplitude, I don't think there's any features of left ventricular hypertrophy here, but interestingly, they're certainly not small either. Given that I think you're probably quite happy that we might be talking about pericarditis here, given the section we're in, we would be worried if the complexes look particularly small to suggest there was large pericardial effusion. In reality, although lead 1 has this small QRS complex, the rest actually all look fine. So I don't think there's any features to suggest large pericardial effusion. In terms of the ST segment, well, let's pull out a couple of leads here. So on the left, we've got lead 2, which is one of our inferior leads. We've got V6 on the right, which is one of our lateral leads. Let's throw an isoelectric line in here, and you can see that that's at the same point as it was when we looked at it in lead 2 before, and you can still see that there's some PR segment depression there, but there's quite clearly some ST segment elevation, isn't there? And if we look in V6, not only is there elevation, but you can see quite a nice concave saddle-shaped appearance there. So that's quite a nice example. And it's non-territorial, right? So you've got inferior on the left-hand side and you've got lateral on the right-hand side. So it's certainly not within the territory of a coronary artery, which would be more in keeping with myocardial ischemia or infarction. What about the T waves? Well, T waves all look to be okay, to be honest. There's certainly no T wave inversion. I think some people might think that the T waves in lead V2 are slightly pronounced. I wouldn't be too concerned by that. Thinking about hyperkalemia, which we've talked about already in this lecture, that tends to be a more global appearance. So I think an isolated single lead like this, I wouldn't be concerned. And actually, the fact that there is no T wave inversion, given that there's ST segment elevation, is quite reassuring, because very often there will be some T wave inversion with our ST segment elevation. And if you're unsure about that, then go back to lecture 2 to recap. Okay, so in summary, we've got a sinus tachycardia here in a patient with chest pain. They've got some PR depression and widespread non-territorial ST segment elevation with a saddle-shaped appearance. And so this is all in keeping with, unsurprisingly, pericarditis. So those features are, there's PR depression, concave ST segment elevation that's non-territorial, and this is all very supportive of pericarditis rather than a STEMI, for example. Okay, so that's the end of this lecture, and this is the final lecture of the series. So let's just recap our learning objectives. So we've gone through hyperkalemia, we've gone through the ECG features of that, and hopefully you now feel a bit more comfortable about identifying an ECG in keeping with hypotassium. We've also described the initial management for patients with hyperkalemia with associated ECG changes, and we've particularly discussed that need to give calcium gluconate almost immediately and to give it repeatedly until you get normalization of that ECG. We've gone through hypothermia and the ECG findings that you get with that. And finally, we've gone through pericarditis in a bit more detail. And we've talked about those differences in ECG presentation between pericarditis and STEMI. In particular, it's the shape of that ST segment elevation, the presence of PR depression, and the fact that these features are non-territorial. So this is the end of the lecture series. As usual, if you have any questions, get in touch either by email or on social media. I'm very happy to try and answer any questions you might have. I hope you've enjoyed this lecture series. I hope that it has helped you in sort of learning how, or recapping how to go through the ECG, and that you feel more comfortable with the ECG as a common medical investigation. So thank you very much for going through all of this with me.